Hi, everyone. Thanks, Susan. Excellent talk. And Debbie and I were just talking in the background about how many cool points that you made and some good take-home messages. So thanks. And Rabbi and Howard and Kimel, thanks for organizing this. This is really cool. So how much time do we have, by the way? Because I can talk for 5 hours about this thing if you want, or we can make it in 15 minutes. What would you
Well,
just
Gil,
agree with the
here's
time
what I
is?
would say is you have as much time as you want, but I would say, why don't we shoot for somewhere in 15 to 20 minutes of updates and highlighting those things which are going to do the following two things. One is how people can themselves stay safe or identify issues, and two, help people to understand where this is going in the long run.
Okay. So I thought, well, some of the things that I wrote down, because I've been trying to read broadly about the science behind it and listening to some of the experts. And one of the highlight things that I was studying today was one of the reports out from the Mayo Clinic by Dr. Polland, who's one of the world's expert on vaccines. And I thought maybe some people would be interested in vaccines, so we can talk about that. Another question that people have been asking me is about should they wear a mask when they go to the grocery store, so we can talk about that. Other people have been asking, how long is this going to go on for? And Susan kind of talked about the ways to handle that from a anxiety point of view, but maybe we can also think about it from a scientific point of view. And then I thought maybe we would take some questions. So, and then also, yeah. So are those some good topics to start with?
Those are fantastic topics.
Okay. So let's talk a little bit about vaccine research and some background things. So people in the world are thinking, well, why can't we have a vaccine? Like the whole world is affected by this pandemic. So aren't the smartest vaccine researchers and immunologists, which Debbie and I are not, why isn't, if the whole world is focused on this, why can't they really make a vaccine like some world leaders have said, within a couple of weeks, and let's just get it going? And I think that, the point that Dr. Polland made today, which I think is really important, is that a vaccine is a drug that's given to a person to protect them from something that they may or may not be exposed to. And even if they are exposed, their disease may be very mild. And even if it's very mild, in this case, it's a very low fatality rate. So for vaccine research for COVID-19, it has to be extremely safe. We do not want to make patients worse. And when they first developed the vaccine for SARS-1 back in 2002, there was some of the vaccines, the testing ones, actually made patients worse because they caused more inflammation. So I think that's a really good point to remember. Vaccine research should be done very slowly, very deliberately, carefully, with a lot of peer review, because we want to. It's for protection. It's not a last minute cure. So I think that's something to really understand. So, at the best, in the best case scenario, it's going to take at least a year and a half. So to a year and a half, according to the team from Mayo. So I think it's really important for people to take that in and internalize that concept, because I think it's a little bit far-fetched to think it'll be done by the summer or even by the end of December 2020. Now, one of the cool things from a scientific point of view that I thought we just very briefly touched on, he went into a lot of detail, but I thought just so people have an idea how the vaccine works. So you've all seen pictures of what COVID-19 looks like under an electron microscope. It's actually a little bit on the large size for a virus, but if you imagine, it's in the shape of a sphere, so in the shape of a ball, and there's little spikes sticking out of it, and one of them is called the S spike, and that's the one that actually binds inside the gastrointestinal tract or inside the lung, that allows the virus to get into the cell and then replicate. And so a lot of the early vaccine research that's going on in the last 12 weeks, by the way, because this disease was only discovered 12 weeks ago, and before that it never existed to mankind. So, but up until now, all the energy is focused on making a antibody, which is a particle in the immune system, to latch on to that binding site. And what Dr. Polland pointed out is that if you just focus on one part of the virus, then there's a lot of pressure for the virus to actually mutate, because it's kind of like if you have a car and you tell your sharpshooters to shoot just to the front driver's side tire, then eventually the virus can figure out, well, they're always aiming for my tire in the front, so I'm just going to forget about that tire and I'll just turn into a three-wheeler. So we don't want the virus to do that. And if there's a lot of pressure and the vaccine's created against one part of the protein, then that can sometimes happen. So they're really advocating to make it as a multi-pronged antibody that would go after all the tires and, let's say, the windows, and so the virus can't mutate as easily, and that the antibodies would be very effective. So I think that's something really smart to think about. So that's really the crux of the idea for vaccine research. So I think we should have low expectations that it's going to be done within a year, and I think we want it to be really good because, above all, we don't want it to cause harm. But that's really a lot of the research efforts that's going to go on, because once a vaccine is created, it could be just like measles and mumps and other things that are no longer as prevalent.
But Gil,
Yes.
on that subject, so vaccine is one thing, but some of these other interventions, whether it's the chloroquine or the protease inhibitors or the retroviral inhibitors, the 20 different drugs that they announced they're putting into super fast trials. If are those things that could be approved for use on a rapid basis? Like if tomorrow we find out one of them is perfect, can that be scaled quickly? What's the story on that?
Yeah, so great question. I think, one of the things, so for Kaletra, or the HIV drugs that they were trying to repurpose, they showed that with a lot of confidence that probably in patients that are really sick, it doesn't work. But it might work in patients that have mild to moderate disease. So they have to test it. But again, you need to have careful clinical trials to determine if it's effective. And like for the Plaquenil, or chloroquine, a lot of idea was, well, let's just go get it, because then if we get the disease, then we can just combine it with azithromycin and then it's cured. So that in some of the early studies is not panning out to be as effective as people had hoped, but it has to be studied, and so they have to test it on a lot of people to see how it works. So I think the thing to concentrate on is that in most cases the disease is very mild, and in the cases where it's severe, like we talked about last time, even in the highest risk groups, those patients that are over 85 that have medical problems, the survival rate is 80%. And so those are the patients that we really have to try to find therapies for. And the other thing to point out, which we covered last week, which I really want to emphasize, is that if patients come to the hospital slowly, even those that are really sick, if we can take care of them with state-of-the-art equipment and focus on them, then their chance of success is much higher. So that's why it's really important, and it's really great that everybody is trying to follow the stay-at-home rules, because what we don't want to happen is what happened in Bergamo in Italy, where the influx of patients was so great that even those that they could have treated couldn't be treated because there was just too many patients coming at one time. And that's what we really want to avoid. And I think we really have to pay attention to those lessons from Italy that are really important. I mean, just to give another example, and I've talked about this, I think we talked about it last time, but if you think about what's happening in Taiwan, they have a population of 24 million people. They're next door to China, and when they started seeing a problem, they closed their borders. And at this point, I wrote it down, they only have 252 cases in the entire country and only 2 deaths in a population of 24 million people. In Canada, we already have more than, I think, 4,000 patients that have had it, and about 40 or 50 deaths. And our population is larger than Taiwan, but we're further away. And so the lesson learned from Taiwan is control the borders, and everybody that's sick stays home. Everybody takes their temperature before they leave their house, and schools are not canceled there. The grocery stores are not canceled. The buses are going, and factories are open. So I think it's really important for our country and our community to learn from the countries that have had great success, like Singapore, Taiwan, and other countries. Now, maybe we can't do it to that extreme, but there's some good lessons to be learned to the countries that have really hit a home run like those, and to the countries that have had troubles like Northern Italy, which, like we talked about, has an outstanding medical system and one of the best in Europe. So
like going back to your question about treatments, if we can give patients the supportive care that they need when they're sick, that's at this point the most proven treatment. The rest has to be studied. And again, it comes down to a risk-benefit ratio. If there's if there's a signal that these medications work and someone is very sick, well, it may be worth it to give the upfront risk of these medications or side effects of these medications for the potential benefit in the very sick patients because of the signal that's there. But if we don't have the supportive treatment in the sick patients, like the ICU, the ventilatory support, ICU doctors, a respiratory therapist to take care of the patients, the resources, the support that's required, then these medications, that small signal is not going to be beneficial. It has to be done with the supportive care. So in the mild to moderate patients, there has to be a larger signal that these medications work, so better studies, because then the risk-benefit ratio tips more to risk than benefit, because the patients with milder cases tend to do okay without medications at this point. So the point is, and I think most leaders in these research are saying we have to do these studies and we have to do them fast. And I'm not a part of a drug regulatory, and neither is Gil, but Rabbi, to your question of is it going to be fast-tracked? Well, I'm sure it will be fast-tracked if the signal is high enough to say it's beneficial.
And one of the things that was
medicines, you sent me something last week. You want to just update people on Advil while we're here on this subject?
Well, last Thursday, the WHO, the WHO, World Health Organization, sent out a report that Advil is not recommended as supportive treatment for fever in people who have suspected COVID or confirmed COVID. And then the following day, they rescinded that recommendation and said there's no longer enough of a signal to say it's harmful. So they said you can use Advil and Tylenol as first line. I would still recommend using acetaminophen as first line, just because there are more side effects with drugs like Advil, ibuprofen, but it's no longer contraindicated.
So anybody listening to this, or a family member of someone listening to this who gets a fever, totally fine to treat them with Advil.
No, well, I kind of agree with Debbie. Like the team at UBC still said that although there's no evidence that it caused disease, they're still recommending Tylenol, and I espouse that because Advil's they're not at all similar drugs, and ibuprofen or Advil is similar in some ways to aspirin, and aspirin is known to cause brain and liver inflammation. So they're making these leaps, but Tylenol is good to achieve most things that Advil does. So I'm definitely on the Tylenol side until it's proven definitively that it's safe.
So first line Tylenol, and it's not contraindicated to use.
All right, for the bubbies at home and for the
don't use Advil if you don't.
Don't use Advil. All right, keeping it simple.
No evidence yet, though. To
okay.
do that.
Yeah.
Good. I'm getting nice texts on how awesome I was, but I should never have prepared because I didn't get to say anything that I wanted. I basically just answered questions.
Oh.
Okay. Now, maybe we'll talk, so just one other point about, how long will last, and Susan kind of touched on it too. So, are we going to be in our houses for a month, 2 months, 2 weeks? And I think one of the things from a scientific point to think about is that the people that are in hospital now in Vancouver, they got exposed probably around 2 weeks ago. So that's why we're always 2 weeks behind. This is different than SARS-1, where there was very little, if not any, asymptomatic transmission. So that's why this disease is unique. Although the fatality and the mortality rate is lower than SARS-1 back in 2002, this one has a lot of asymptomatic transmission. So you don't even know you have it, but you're spreading it. And so it could be anywhere from 5 days up to probably 29 days of delay until you declare that you have the problem. So we're always 2 weeks behind. So the cases are doubling every 5 to 8 days, just like in other countries. And I can tell you that, we just got an email at the end of the day. There's already 725 cases in BC, and 66 in hospital and 26 in the ICU. So we expect that to go up, but as long as they come on a slow enough time frame, then we can give everybody state-of-the-art treatment. So that's why we strongly recommend that people stay home and relax and, go for short walks, but try not to congregate with other people because you may be an asymptomatic transmitter, or you may, hang out with somebody that is an asymptomatic transmitter and expose somebody that's at higher risk. So we covered that last time, but I think that's still the best advice that we can give.
Okay, you want to keep going down your topics? Or you want me to?
Sure. I thought this is an interesting thing about masks, because I read quite a bit about it. So, like, should people wear masks when they go to the grocery store? So I'll tell you what I think, and I don't necessarily agree with what everybody else agrees with or says, but this is my view. I think a mask, you have to think of it as a medical tool, and so if you know how to use it properly, it actually could be very protective. And the reason why in the media and in reports when they're look on the websites is to say not to use a mask is because you'll see that a lot of people touch them without washing their hands, or they'll eat under them, so they'll prop it up and have a chocolate bar or drink coffee under it. Those things put you at higher risk. But if you wash your hands, put a mask on, and then go into the grocery store and you do not touch your face or your mask, do your grocery shopping, then wash your hands and take the mask off, you do reduce your risk a little bit, because if you happen to be near somebody that's coughing, then then your risk of exposure is lower. So that's how I would say it. If you know what you're doing and you're very careful not to touch your mask, like they teach us in medical school and in residency, and now they're really emphasizing, then it's okay to wear a mask. But if you're going to put it on and you're going to eat around it, or you're not going to take care of it, and it's going to and you're going to put it on your nose or your forehead or on your chin, like I saw today at the drugstore, then that's not very smart.
Or touch surfaces and then touch it.
And the other thing is, when you go to the supermarket and you see people wearing masks, that's really good, because if they have it, they're not going to transmit it to you. So when I see somebody wearing a mask, I give them a thumbs up, because not only if they're doing it properly, they're going to protect themselves, but they're also doing a service to those people around them if they happen to be asymptomatic transmitters. So if everybody wore a mask and everybody knew how to wear a mask and everybody washed their hands, there would be no transmission. So that's that's the extreme, but of course we can't rely on everybody doing it properly, but that's the way it is. Just like if everybody drove properly and wore a seatbelt and was very careful when they're driving, the accident rates would go down. So it's very similar, but as soon as you have some misbehavior, then it puts everybody at risk.
So Debbie, this one is going to be more for you, because I think your interaction is more on boots on the ground. What are you seeing at St. Paul's? Like, what's happening at the hospital? How are you managing capacity? Is it as horrific as the reports we're hearing from other places?
It just like us totally separate from what Gil was talking about with masks. So a different topic, or just?
Yes, totally separate. I'm monitoring the chat. You'll think of me as Anderson Cooper.
Oh, okay.
And so
I think
viewers want to know what's going on in the hospital.
The hospital's been preparing significantly for this, and it's really in preparation mode this time. We have not started yet the steep part of the curve of hospitalizations at St. Paul's and most hospitals. Each hospital is getting there's now today in British Columbia, I wrote it down, 66 people in hospital throughout the province. And so that's spread out between different health authorities. And so we are seeing less patients coming to the emergency for other problems. So less patients getting to admitted to hospital, all elective procedures being canceled. So less people staying in hospital after their procedures. And so we're and more patients going to their family doctors or calling the health lines and not presenting to the emergency room. So the hospitals are actually, I don't want to say the word because we never like saying this word, but they're shaket now. They're a bit shaket. They're quiet right now. It's a bit of a calm right now in the hospitals. So we're expecting that things will start changing based on 659 patients in BC yesterday. Today there's 725, and the numbers increasing. The delta is increasing every day. So we're expecting by next week that we'll see more of a surge.
Yeah, I just want to chime in on that. They are only testing people in hospital and healthcare workers. So the surveillance on that is blind. And I don't know if you saw this, the New York Times, in order to compare region to region, stopped comparing actual number of cases and only compared deaths. They thought deaths were the only reliable statistic. So I'm just curious what you think about, for those of us glued to the coronavirus dashboard or world meters or whoever else you're following to see how things are going. What metrics do you think are the important ones for us to look at here?
Well, I think the screening in
Admittedly.
British Columbia is going to change. Lots of advocacy is working towards testing more people. Most of the professionals and medical directors in infectious disease and infection control are really pushing towards testing more people. So that may end up being a metric that's helpful, but I agree with you, right now it's not. I'm not an epidemiologist, but I do, by my readings, and Gil will be able to answer more, that definitely hospitalized patients and intensive care unit patients are the most valuable numbers right now, and then in time mortality in British Columbia. Right now I think it's mostly following the hospitalized and the ones requiring intensive care units.
I mean, the other stat that was on the internal site today was that of the 725 patients that have been cases in BC, 186 have recovered. So 26% have recovered. And so now the question is, can they get reinfected? They might be able to, because nobody knows how long the durability of this immunity is. And also there may be different strains. So just because you get it once doesn't mean that you're protected for life. And that's different than SARS-1 and MERS, right? The Mediterranean one, the immunity looked like it was lifelong. It was very durable, whereas SARS-1, it wasn't. It was very short. But that virus kind of went away a year and a half later when it first came in 2002. So nobody really knows. And like we said at the beginning, this has only been 12 weeks since it's been introduced to humanity. And so it's a lot, the whole world is focusing on it, but we haven't had that much time to research. And for instance, like Ebola, it took them 6 years to make the first vaccine.
So someone asked this question on the chat, are you immune once you get it? So this is not like the chickenpox where you want to expose your children so they get.
I don't think so. The one thing that Dr. Pollan did say, which I thought was really interesting, he said that he is hoping, he didn't say that, he said he's hoping that because it can cause moderate illness and it really goes into the lung, that those that have more moderate or more severe disease might be immune because their immune system is really taking it seriously. And the people that have mild disease, well, then they had mild disease, so it may not be as much of an issue. But that's what I understood when he talked about it. He's hoping that it will confer some immunity. And he also talked about the comparison between measles immunity and mumps immunity. And for people that get the vaccine for mumps, because there's no background re-exposure or boosting, then mumps can actually, the immunity for mumps is not as strong as it had been in the past when there was always background challenges. Whereas the measles type immunity is thought to be more lifelong, and that's why it's such a great vaccine and everybody should get it, of course. And let me just add one other thing about vaccines. As you can tell, I'm a very big believer, I really trust the data on vaccines. So one of the questions was, well, let's say my kid now is due for their vaccine. Should we be going to the family doctor's office to get a vaccine for, their MMR or whatever? And so the guidance on the American College American Association of Pediatrics was that a family doctor should really try to space out the appointments, because you don't want to be in a waiting room with 14 other kids waiting, and some of them may be exposed or not, but they really recommend to continue with your normal pediatric care, just to use caution. And the family doctors are aware of this, but that was something. And for adults, if they're, if they didn't get their pneumococcal vaccine or their flu vaccine, well, then maybe if they're already isolated at home, maybe it's not such a rush to go out and do it right this moment, because you're not going to get pneumococcus or influenza at home anyway. So he was just think about the risk-benefit analysis, like Debbie always talks about. So to try to do the best that you can in terms of normal, routine GP healthcare, but just be cautious that you don't want to expose yourself to unnecessary risk if it's not urgent. And I think that was the point.
Okay. Do you still have things on your list, or you want me to? Maybe I should turn to Kimel. Kimel, have you gotten texted any questions?
I don't have any text tonight. For those of you who do want to text, who maybe can't see the chat but are listening by phone, my phone number is 604-399-9423. I do see a question here that I thought was quite interesting, was the diabetic or pre-diabetic persons, are they particularly vulnerable to have more severe symptoms with COVID, and how are they treating these patients?
So yeah, the studies show that those that have more severe infections that are older, if you have diabetes, it's higher risk. But it's not the highest risk. The highest risk are the older patients with high blood pressure. And so one of the other studies I was looking at was saying, and Dr. Fauci pointed this out, he was like, well, when he was looking at the patient populations, he said that almost 70%, if I remember correctly, of the patients that had really severe disease had hypertension. And that's why this idea of the ACE inhibitors, which many people are aware of, was thought, well, maybe that's making it worse. So that's why they're studying whether or not people that are on ACE inhibitors are at higher risk. But the latest information from the American College of Cardiology and the Society of Hypertension is to remain on your current medications and do not change it. But with respect to diabetes, the studies, the patient population from Italy and China that I looked at, those that have diabetes are at a little bit higher risk.
Not the highest, and there was nothing around pre-diabetes.
Right.
There's no signal with pre-diabetes.
Yeah.
All right, so I'm going to ask a tough question here. Can we get some thoughts on delivering food to the elderly, and if we're supposed to be social distancing, but let's say, you have a family of 5 and grandparents are celebrating Passover alone. Should you get together? How would you recommend managing those kinds of situations?
Great question. So let me try, and then maybe Debbie will add in also. She's actually more of an expert on nutrition than me. I think, so let me answer in a couple of ways. So some people said, well, is it better to go to pick up food, kosher food for the Passover Seder, or is it better to have it delivered? So with that simple question, I would say, in my view, I think that it's actually better to have things delivered to your house than go out, because you can collect the food, especially if it's heated food. The chance of it being infected is extremely low because heat kills it. We know that. And so if somebody delivers your food, you're just less exposed. So I think that if I had the choice of going to pick things up or have it delivered, I would choose delivery. But the thing to really emphasize, and I talked about this with Jonathan, and also with Dan Rabibo, and
just everybody knows that Jonathan Leipzig is
Jonathan Leipzig and Dan Rabibo and Arnold, my new best friend and advisor. He was really very thoughtful about, really, for our community, to make sure that we don't have people that are hungry during this time. And it's really important, because there's one thing to be exposed to a virus, but there's another thing to have malnourishment and fear and being alone during such a stressful time. So I think that having good nutrition and being comfortable asking for help, I know for a fact that, if anybody emails Kimel and says that they need help, we will deliver food, or Debbie and I and all the people that I mentioned would really find this very important, to make sure that everybody has food to eat, because you want to.
Your guilt. So let me just jump in here. I look, getting people food is obviously a priority, but I'm going to ask the harder question, and maybe Susan is available to jump back in on this to help us balance that. there's a balancing act here between the social distancing and the depression and trauma of being separate from family members who are almost always together for these kinds of events. I can tell you, I know numerous families. I can tell you there are many people on this call who always have Seder together. And the children being away from their grandparents is going to cause some stress and anxiety. So maybe I'm going to ask both you and Susan to talk a little bit about weighing the cost-benefit analysis of that. If nobody's presenting symptoms, they haven't really been out and about so much, can they get together? Does that pose a new risk?
Can I just go first, Susan?
Yes.
I think so. I was hoping that maybe, and I hope it's okay that I'm going to push back a little bit, Rabbi, but I was hoping that the Rabbinical College would be lenient and allow for virtual seders, and just like we're allowed maybe Shabbat elevators and to leave the oven on, that you could just have the computer on before the holiday starts, and that you could just share it with your family. But I understand that that's not possible. But I was hoping that there would be some leniency on that, because I think that Judaism really prioritizes the family being together. And Debbie, we were planning to go to Montreal with my dad, and I think my dad called in. So if he's listening, I was really looking forward to being there for Passover with him. But so I think that now with the technology so good, like I feel like I'm sitting in your office with you, just looking at you now, Rabbi, and it's not the same. And but I was hoping that maybe the Orthodox school will allow a little bit of leniency, just to show how important in Judaism it is for people to be together.
That segment's censored, right?
Yeah.
No, I'm happy to weigh in on that afterwards, and we can discuss we can debate this also. But okay, aside from your wishes of the rabbis, let's
Sorry, and I hope it's okay that I opened my mouth, but that's.
Should have been wearing a mask during that segment. I'd be interested to hear what Susan says, just because everything we should be doing now is a bit of the trade-offs that we accept, and the risks and the benefits of things. So from a psychological point of view, I think you're the expert. So
I mean, I do think it is a trade-off between, the medical risks and the psychological, obviously. I do think it is really important for all of us to really take seriously the medical guidance around social distancing, really for the perspective of, flattening the curve, but potentially like having life at some point go back to normal, right? So, I think that it's not an easy question to answer. I do think with technology, we have a lot more flexibility. Like we've been doing, we had a family FaceTime tonight with my whole extended family from all of our places. We've dropped off groceries at my parents with my kids in the car so they can at least like see them. I think like doing things to really boost the grandparents' spirits, because I think it is truly hardest on the grandparents who really cherish those times together, finding ways to connect as much as possible. But I think that, it is risky with the seders. And so, I think what I would say personally, and I'd look to the physicians to talk about that more, but it also depends on where people are at with their own isolation. Like in my family, for example, everybody but us were away on vacation and came back and are currently isolating, which is why we've been dropping off groceries to them. And so they're going to be coming out of isolation, like I think 2 days before Passover. So nobody has seen anybody or left their house really for 2 weeks. And I think that's a lower risk for getting together versus people who are kind of still going to the grocery stores and have potential for exposures, and kids going out and maybe, like seeing the neighbor kid and hopefully having distance, but maybe they were playing soccer. Like there's so many factors to consider around what the actual contacts have been in the last while. So I personally would say, you know, for the safety of our grandparents, who I think are who we want to protect the most in all of this, to, you know, find ways to connect virtually and create Seder this one year, you know, that's a little bit different, but ideally still is connected in some way.
So, Susan, I'm basically, just to brass tacks it, summarize it, you are favoring immunological health over mental health for this Seder. For most people, there's obviously going to be the outliers for whom there could be other very specific.
Yeah. Well, so because I think that if you are connecting, like if you can find ways to connect, then there shouldn't be the psychological impact. Is kind of the bottom line.
Okay.
Like if you are connecting with grandparents, if they're on, if every day everyone's seeing each other's faces and having a conversation and a check-in, then you're much less likely to see a psychological impact of the social distancing.
Okay, that's a great way to put it. So let me just to chime in a little bit on the rabbinic front, answering Gil's point.
I'm sorry if I know you like
No,
debate.
you know, the truth of the matter is it's very out there, and so, you know, it's worth chiming in. There's in this particular area, there's a difference between Sephardic rabbis and the Ashkenazic rabbis and some of their treatment of it, turning on lights on Yom Tov, for example. Let's just without diving deep down into it. I think part of the issue is from the rabbi standpoint is, and I'm sorry for getting sectarian on this, but there are some streams of Judaism that have said things like, it's okay to drive if you're driving to shul. And it became very difficult for people, just as a sociological observation, it's very difficult for people to hold that line. That once you open up Pandora's box, it's completely open. And so if you open up Pandora's box and say, we're going to allow for electronics on this Passover, then electronic communication is on Shabbos and Yom Tov is then going to become a floodgate. And one of the great things about Shabbos from a mental health perspective, and my wife tells me this all the time, is that the brain has something called a default mode, and it needs to be not stimulated and pounded with messages and blue lights and all of those things. And so the rabbis are protecting another piece of mental health, which is much greater, and a piece of sanctity, which is much greater than just this Pesach. And so I'm actually very glad to get Susan's input on this, because she's basically saying, create your mental health issues elsewhere. I will say, though, that Rabbi Herschel Schachter specifically said, if there are people who you are worried about from an acute standpoint, that means that you're on a real suicide watch. There's extreme depression, extreme anxiety. I'm not clinically able to define it, and each person's diagnosis should be evaluated individually. But in those cases, Rabbi Schachter said, you are allowed to use the electronic communication. But the way that I would understand that or frame that is, diabetics are allowed to use blood sugar monitors on Shabbos because that's part of their management. And people are allowed to use hearing aids on Shabbos because that's a safety issue. Those are all electronic reproductions or interfaces. But everybody understands that that's for a specific category of those who are infirmed. And so there is a wide leeway for the infirmed in this situation. We're going to try and that's what we're doing. Like we do the Havdalah, we're doing Kabbalat Shabbat. We're going to try and do a sort of a learn in before Pesach to try and create some of those things. But I think it's also very important to do that individually. And just another plug, I really, really think it could be a beautiful thing. Find a couple people, write a note, that says on it, not to be opened for the Seder. Put it in the mail, and make sure it gets there before Pesach, and then people can surprise themselves and they can open up notes and pictures and drawings. And I think that that's a really important piece of this picture. But I'm going to leave this particular subject because I don't want to overdo it, because I know there are a lot of people who have many questions. I just got
just to answer your question about the delivery of food.
Yes, please answer the question about safety of delivery of food.
Yeah. Again, food insecurity or not having access to food during COVID time is a risk in itself. And as Gil said, we can't let that happen to anyone in society. So delivering food, doing the shopping for someone, preparing food for someone who isn't able to prepare for themselves, all those things are necessary if someone isn't able to secure their own food for themselves. And so then it just requires common sense of how to handle the food, both from the person who's delivering it as well as from the person who's accepting it. But yes, I think in this time, like in any time, we can't let people not have access to good, healthy food.
I also just want to, what's great about this platform is that we're getting lots of fantastic crowdsourcing. So a shout out to Anna Wallach, who's a GP, and reminding me that people should know that the family doctors are open and they're doing as much as they can by telemedicine. But they will see you in person if necessary. And they're fully aware of how to protect patients. And they've set up their practices with those guidelines. But I should also add, and I think Anna said this to me last week as well, if not others, you have to be totally honest with your GP and with their MOA. I believe it's safe to say, and anybody can chime in on this, medical office assistants are trained in confidentiality, and people should feel comfortable speaking to the medical office assistant, giving them your full symptom profile, and then let the doctor and or her staff manage your manage how you speak to the doctor, engage with the doctor, etc.
Can I just say one other thing about food? So we did food delivery with which company did it? I don't remember. Well, Heidi told us where to do it. And so I think just again from a exposure point of view, I think people should look into it. You just go on the web, you click what you want, some broccoli or whatever, and it comes, and you don't have to worry about it. So I think it's a smart thing to do. I think we should try to avoid. I think it's much smarter to go out for a walk around the block and not be exposed to other people than go in to the supermarket. And the one thing I did want to add is that in New England Journal of Medicine, they had a very good paper about how long this virus specifically lasts on different types of material. So I thought maybe people would find this interesting. Would people find it interesting?
Go ahead.
Okay. So
everyone's muted. So
okay. I'll be very brief. But this is on copper. Actually, it survives the least amount of time, less than 10 hours. Cardboard is about 20 hours. Stainless steel is one of the longest at 80 hours, and that's why they think that, in the subway on the stainless steel bars, could be higher risk. And plastic is about 70 hours. So if you're getting stuff at the grocery store, and I think it's worthwhile to wash it because you don't know who touched it. And I know it sounds like it's very obsessive, but I think it's good practice to just, when you bring things into your house, just to rinse them down. But cardboard doesn't last that long, so that's why they said mail is safe, because most of the time mail's in the mail for longer than 20 hours anyway. Yeah.
Gil, you're not really a good paranoid Jew. How do we know the mailman isn't a carrier?
It's possible.
Sorry, the postal carrier is not a carrier.
It's possible. It's possible. You're right. It's possible.
So anyway, Rabbi Gibbs had one comment he wanted to make.
Yeah, so Rabbi Rosenbaum mentioned the decision of the conservative movement in the 50s, as in recognizing how many people were already driving to synagogue, essentially making the argument that if you are driving, you should drive to synagogue instead of staying home, but you should only drive to synagogue. Just an interesting sociological note, which you can take it in any way you want. At the time that paper was written, the number of people who drove to conservative and Orthodox synagogues were the same percentage. Just in the way that, especially in the 50s, many attendees of Orthodox synagogues, were not personally observant. By the end of the 20th century, the thing completely switched, where most people drive to conservative synagogues, while members of Orthodox synagogues tended to become more religious, or, the generation became more religious over time. And so, part of the decision of what you do and don't allow in some ways is, kind of creating that self-selecting community, of how much, essentially the congregants, are going to be taking those practices seriously. So especially with the question of, for people who are, encouraging or not encouraging people doing seders over Zoom, I know that at least in our community, like, I'm not going to be doing any sort of like Zoom things happening during Shabbat or Yom Tov. Something that, there are conservative rabbis who are, I personally will not. But there's no question that in 10 years, I think we are going to see a very different attitude towards Zoom technology and Shabbat, across the Jewish world. And it's just going to be interesting to see the way that unfolds. But just, I didn't want to, I just wanted to give a little more context to what Rabbi Rosenblatt, casually mentioned.
Okay, thank you, Rabbi. So, Gil and Debbie, you had some other topics. Well, let me actually, Kimel, you said you have some questions coming in. So maybe, Kimel, you want to throw some questions out in?
Thank you. I have a question from, can everyone else, Rabbi, can you mute everyone else?
Let me just, I'll survey who's muted and see who's causing the trouble.
So this is from a young parent who's asking, at what point is the right time to go to the hospital if you do believe that you potentially have COVID, being that, as, let's say, not even a young person, but let's say, a parent or a grandparent, everyone's reluctant to go in. They're worried that if they don't have it and they go in, they could get it. But at what point is the window of time that goes from bad to worse and you miss the opportunity for proper intervention and then potentially can be at the point where you have to be intubated? What are kind of the signals that someone should be heading to the hospital? Also, this falls into the question of a lot of people don't have GPs in the Lower Mainland, and so they can't call them to ask for advice, and the 811 number is totally overflowed. So what would your advice be?
So great question, and that's really the crux of the matter, because like we said, most people have very mild disease, and if you went to the hospital, they would say go home anyway, even if you were positive. So the people that need to go to the hospital are people that are short of breath. What does that mean? That means that you're sitting down and you feel like you can't catch your breath, as if you're jogging. Because what the studies show and what happened in New York and Italy and China, all the centers, is that people that are admitted to hospital, because they're too sick to go home, those that need to go to the ICU often need to go very fast. So the take-home message is that if you have COVID, but your symptoms are very mild, then you're going to be sent home. But if you're at hospital and you're short of breath, then it's possible that you'll need more airway support. So I would say that if you're at home and you have shortness of breath or chest pain, meaning that you can't catch your breath, then I think you should go to the hospital, regardless if you have COVID or not, because we know that the window can be short. So some people really need airway support fast.
Yeah, I mean, that's the definite take home is any, concern of shortness of breath that is an unusual thing. I mean, this is hard to say because, it's in this discussion about go to the hospital with shortness of breath is under the umbrella of you having COVID, right? So not everyone with shortness of breath has COVID and needs to go to the hospital. But if the question was directed as if you're concerned about having COVID-19 and what would your symptom be that would bring you in, mild to more moderate symptoms. People who have fever and cough could also progress very quickly. So, it is important to be able to get in touch with a frontline family doctor or 811 over the phone if you want to have someone help troubleshoot that question around, I have a fever and a cough, at what point would I go to the hospital? But in general in medicine, like this is a really hard time, like because the avoidance of the hospital could be harmful, and that question is a really good one because what symptom beyond like before shortness of breath, should you go to the hospital, is there's not enough in the literature to say what other symptom the next step is a worsening course. You know, high fever, cough are two of the symptoms that are often associated with the people that have shortness of breath. So those are the ones that I would loop, you know, group together to say, you know, have a low threshold to go to the hospital if you cannot get in touch with 811 or a family doctor. Shortness of breath in itself, for sure, go to the hospital. The other thing to know, and I've been doing a lot of virtual medicine on a lot of new patients, internal medicine consults and follow-ups on my patients, is to make sure that we're not diverting resources away from people who have non-COVID complaints. And again, you know, calling family doctors to see, you know, what threshold should I go to the hospital or go for my blood work. These are really, really like on the minds of a lot of people out there. A lot of my patients are like, well, when should I go to the hospital if my infection of my leg worsens, or, you know, if I get faint or dizzy from my anemia, should I go? You know, a lot of questions there, and these are tough times of when to direct someone to the hospital. And again, I don't want people to avoid going to the hospital, or avoid going to their family doctors for blood work because of COVID, and putting their lives at risk for other reasons. So it's all about the risk benefit ratio.
Debbie, on that
yeah.
risk benefit ratio, an even more pedestrian case. Someone in your family has a sore throat. Someone in your family has a stomach virus with a low fever, or headaches and muscle pain and fever, kinds of things that a year ago would be no big deal. But those are like out there reported symptoms. Do you quarantine them in the house for 14 days? And with all the psychological trauma that takes and all the difficult, like when do you shut people in the room? And when do you say, okay, this is no big deal?
Well, I mean, I think I sent that form to you last week about isolations. Remember last week?
Yeah.
Self-monitoring, self-isolation, isolation. So, I mean, if that's a different question around, not about going to the hospital, the one you're asking, but yes, for sure, if someone has any symptoms suggestive of COVID-19, which, you know, we talked about cough, fever, and shortness of breath being the ones that would you group together to say maybe I should go to the hospital, but all the ones you mentioned, like anything that feels like a cold, a sore throat, muscle aches, joint aches, fevers, GI symptoms like the diarrhea that you mentioned, all those things definitely would require self-isolation. Those are the people who should not be going out to the grocery store. They should not be definitely physically distancing by the 2 meters. So those people should definitely be isolating at home.
I also
want that they're in contact with are people who potentially had contact with someone who may have COVID. So they also have to isolate. And actually, I marked the pages on the public health website and the BCCCD. It actually says that if you've been in contact with someone with presumed COVID, you should isolate for 14 days minimum, or like 14 days after you develop symptoms. And so it's actually, those people definitely have to isolate as well. So it takes a whole household that's not even allowed going to the grocery store if one family member has it.
Wow. One family member has symptoms?
If one family has presumed, meaning just the symptoms, everyone in that household who's contacted them should not be going to a grocery store, should not be leaving, have any contact. Yeah.
Just also on the flip side of this, I got this from a rabbi's chat group that's in touch with an immunologist in New York, and he writes that the official guidelines from the Department of Health say the person who is more than 7 days out of the onset of their symptoms, and they have been without fever and have resolving symptoms for at least 3 days, no longer requires quarantine. Does that sound correct?
So it's interesting. I said 14 days, but because I don't want to say 10, but I just checked it before this because I knew I was challenged on this question last time. But our website actually says, the BC CDC and the public health website says 10 days after symptom resolution. But if you don't have symptoms, but if you've been exposed to someone with presumed COVID or confirmed COVID, it's 14 days.
Wow.
Yeah. And it's all on the website. I can send you all the links again.
Okay, I'm gonna go. I know that sleep is or lack of sleep creates a compromised immune system. So I'm going to close this in 10 minutes. I'm going to go back to Kimel for a question.
Hi. So there's some questions in the chat about serological tests, which might be available by the millions and can be self-administered. Do you guys have any information on that?
Well, I think Abbott Labs is working on it, but it's not available in Canada yet. The one we have at St. Paul's is the Roche one, which is very effective, but you have to put they do the Q-tip test either in the back of the nose, which is better, or the back of the throat, and collect some sample, and then it's a PCR amplification. So they're looking to amplify the virus. So it's not an antibody test yet, which is the future. That's much more effective because you'll know if you've been exposed. Whereas now we're looking for the virus whereas in the future we're going to look for the body's antibodies against it. So we're just not there yet.
The microbiologists at our hospital and probably other hospitals are doing studies to see the antibody levels in the resolved cases in BC. So patients who have had COVID confirmed and now asymptomatic and recovered, looking at their titers of antibodies. So we don't have the answer yet. I'm sure studies will come out from the other countries as well. But also about the test, the swab, there have been some reported cases of someone having a negative swab on like day one and then retested 3-4 days later and having a positive swab. And whether that's because they didn't have COVID on day one and then developed COVID on day 4, or whether we have false negatives, meaning your test is negative but should have been positive, we don't have the answer for that yet either. So lots of studies happening in our labs, microbiologists, around the specifics of the test and also of the antibodies.
Another question that came up was, so the news talks a lot about patients who are on ventilators and kind of the worst case scenario. But I think for people trying to deal with anxiety and the worry of getting sick and what that looks like, what does it actually look like for a patient who is in hospital who doesn't have to be ventilated? Like, what is the process that's happening to help make a patient better so that they can leave hospital? Like,
so
treatment.
Yeah, again, all the treatment is supportive, and so the only patients that are admitted to hospital at St. Paul's, it's on 7A, one of the wards. The only reason why people that are admitted is because their risk of requiring more airway support is higher, or they need less than 4 or 5 liters per minute of oxygen. So that's the reason for admission, but there's no real treatment. Sometimes people also come because, there's a slightly higher risk of arrhythmias, and also they want to monitor the kidneys and stuff. But for the most part, out of the 726 patients in BC, now this is over time, but very few, less than 10%, are in hospital overall. So that's why people are admitted, because they're at risk of requiring more aggressive mechanical ventilation.
And actually, the few patients that the hospitals in Vancouver have seen are that they're admitted for other reasons, like other infections, bladder infections, ankle fracture, like something else that makes them stay in hospital. So it's not we haven't just seen patients come in for the respiratory reasons, but they happen to have COVID positive, but they have another reason to be in hospital. And then just to answer your question, what's it going to look like? We don't know yet what it's going to look like. But, just from reading what's happening in Italy, and of course, we're also limiting visitors in long-term care facilities in BC, as well as in very strict on limiting visitors to the hospitals. it's going to be a different journey for patients in hospital potentially. Well, most likely where they won't have visitors there. And so that's also a scary reality. So definitely supportive care from, as much as we can for respiratory supportive care, IVs, nursing care, physician care, pharmacist care, but the spiritual care of it maybe, and the supportive care from family members visiting, we may see that that's going to not be there as it has been for patients when they usually go to hospital. And also maternity wards, not having family members coming and visiting their newborn babies. So it's going to be a different world in the hospital than it has been in the past.
All right, well, I'm going to wrap it up here. Gil, Debbie, thank you so much. Susan as well. I really got so much from all of you, and really appreciate your giving 2 hours to our community for this. Also appreciate everybody who joined and all the crowdsourcing, Kimel, Rabbi Gibbs, and all of the work that you did. A real shout out to Kimel and to the Shaare Zedek staff. Kimel kept us really very in business here, and she is juggling a lot and making sure that all these new electronic things are happening. And hopefully everybody also got our Pesach under isolation guide that came out today. So I just really want to thank Kimel for all her help. And again, Susan, Debbie, Gil, your wisdom has really enlightened me, and I appreciate your giving your time for us. And everybody, please stay safe and stay connected.
Thanks, Rabbi. Thanks for organizing it.
Pleasure.
Okay.